Good evening, everybody. Well, I say good evening is because we're recording in the evening. I don't know what time you're listening to this, but let's presume it's in the evening. Good evening, everybody. Welcome back to the next episode of the Dental Implant Podcast. I know I keep promising that I'm going to record more of these, and then I don't. It's a bit sporadic. Well, the good news is I now have a lot more free time to dedicate to this. So unfortunately, you are gonna have to listen to my voice a little bit more frequently. So I'm really excited today to have a colleague, Dr. Millie Morrison. We've actually worked together in the same clinic before, and Millie is an absolute whiz with Invisalign. We are going to be talking about how to integrate implants and also integrate Invisalign for those patients who want to have both. We're gonna, I'll be picking our brains because I find it interesting as well. So just before we start on that, I will again just go into the Academy of Implant Excellence, which is now up and running. And I'm getting some very fantastic feedback, which is exactly what I wanted. If you'd like to learn more about the Academy of Implant Dentistry and course content, please reach out to me. I'll be very happy to discuss that with you. Anybody in the UK who's interested in mentoring on any level, whether you're getting started into implants or whether you want to progress to sinusless, full arches, anything along those lines, I'm also happy to help there. But I do want to make sure that I can serve you and help you to the best of my ability. And secondly, you're going to be a good match for the Academy because I'm very much building a culture of mutual support, learning, safe environment, and that's really important to me. Okay, so just before we start, Millie, can you tell I know about you, but tell the listeners about you.
Hi everybody, and thank you, Pav. My name is Millie Morrison, and I have been a general dentist since I graduated, but then I really found my passion a few years ago, about seven years ago now, in clear aligner therapy. And since finding my passion in clear aligner therapy, and just so you know, when I left university, I was like, I'm never doing another exam again. I really hated orthodontics. I was like, that's it. I hope that I won't be doing that. I really thought my journey would be into more restorative, and then that hasn't happened. I found this passion, and when you find a passion for something, it really reignites your fire for going into work, for learning more. And then I just wanted to really push myself and be able to deliver the very best I could for my patients, and really enjoy the work I was doing. So lo and behold, I am now doing more orthodontics than anything else, and done multiple postgraduate courses, currently doing my master's in clear aligner therapy. So it's really made me do a 180 on what I thought I would be doing when I left university all that time ago. And the opportunities, mentoring, teaching dentists all over the world how to implement it into their practice with the restorative side as well has been absolutely incredible. It's taken me on this whirlwind. So I always say, Pav, and I'm sure you'll agree, that one decision can change your life. And my decision to really go all in with clear aligner therapy and Invisalign as the brand that I use really changed my life completely.
Yeah. And I think it's your ability to integrate with restorative and implants. This is why I wanted to speak to you, because we have done a few cases together where patients have wanted implants and Invisalign at the same time. So, I mean, the listeners know that I've been banging on about implants for a very, very long time. They know that, oxygen doesn't bind to hemoglobin in my blood is not iron-based. It's got to be titanium-based because that's the only thing that makes sense. My wedding ring is titanium. I live and breathe titanium. I'm sure if I was sleep talking as well, that I'd be talking about grades of titanium and such. And I know that you're kind of the same with Invisalign as well. So what I want to get from your perspective is, let's say a patient comes in, and I want to split this up into two factors, okay? And let's keep it simple to start with. There is enough space for me to put in an implant, predictably, and I know where everything wants to end up. But the patient wants alignment as well. They want an overall nice smile. What's the best way to harmonize the treatment plan between you as an Invisalign dentist and myself as an implant surgeon? Because everything's restoratively driven. So what that means is, even if I've got enough bone where I know I can get an implant in, I need to know where your treatment plan is going to finish up, because that's where I need to put the implant. And sometimes I've got to modify my implant position slightly to give the patient that best outcome. So how do you work with dentists who implants in those types of cases?
So, I mean, it's really interesting how you can get both parts to integrate so well. And I think one of the things that's really amazing when we're thinking about where orthodontics and where treatment planning is today is that a lot of treatment planning is done digitally now. So we can predict where the teeth are going to end up before we even start. And with things, how they're progressing, that's a really great question and a really great scenario. And I think where we are now with treatment planning and how everything can be treatment planned digitally before we even really touch the patient opens up this world of opportunity, because we can predictably say, well, this is where the teeth are going to end up. From an alignment point of view and therefore a restorative point of view, we know where we want the crown of the implant to be. And if we've got enough space, then typically how I work is I quite like the implant to go in. I'll align the teeth whilst it's integrating. And then by the time we get to the end of the alignment, we're ready to restore the implant crown before we go into the retention phase.
Yeah. I mean, that's kind of like how I work as well in these types of cases. So it's really important that I convey to the Invisalign provider that, look, this is the position where the patient wants the implant to go. And I mean, I used to do a lot of Invisalign as well. I have a rudimentary understanding of the system. So I kind of like know what actually this is kind of like going to be the sequence of everything. But I think if effectively what we're saying, what it comes down to is communication between patient, me as an implant surgeon, and then yourself as the Invisalign provider.
Yeah.
Because what we've got to do is we've got to harmonize all of those stages. And that's no different as than if you were doing any other type of interdisciplinary work. It comes down to clear communication and making sure that we're putting the patient's interests first and making sure that we're all aligned with the patient desires.
Absolutely. So, I think, and that communication is so important. So, say if I saw the patient first and they wanted alignment, they wanted implants, then typically what happens is I'll sort of oversee the case and then I'm doing that communication. And the great thing with, the online planning platforms that we have, we can now integrate CT scans. I can export final SDL files. We can export videos. We can export pretty much everything. And, when you really dive deep into the biomechanics, we can increase that predictability as well. So you can really communicate in lots of different formats between, yourself, the surgeon, and the patient. And then if the surgeon, so if say you were to see the patient first and then you were to refer them to me to do the Invisalign part of the treatment or the alignment part of the treatment, then, you'll probably be overseeing it. And, I always think of it as like the manager of the case. Because you're the one, you're managing the case, and I work very multidisciplinary. I like that other people do what they're very good at, so the patient gets the best quality outcome. But I'll manage the case. I'll be project managing it, but you can have all that, and you can get all that information in a really clear way. So you know exactly where you're putting the implants. And if you wanted stents from, labs, or if you were going to make your own stents, again, because we can export the SDL files, you can have those made ahead of time.
Yeah. So the next scenario that I wanted to discuss with you, and this is something that I sometimes bully Invisalign providers into this, even though they may not like it so much, but I push them into it a little bit. And from my perspective, it's just from kind of like a treatment planning perspective, okay? Yeah. And that treatment planning perspective is really quite simple. Is if I don't quite have enough room, or it's kind of like there's more crowding than what I wanted, and I've kind of like just about got enough space. Quite often what I'll do at that point is I will turn around and ask the Invisalign provider, I don't bully them into it, I ask very, very politely, I say, right, okay, we want to put an implant in this position. Let's say it's an upper premolar, okay, and the canine and the second premolar needs to move around it, okay, and it's the first premolar that we're replacing. I'll quite often turn around and say to them, can you do me a favor? Can you move the canine and the second premolar into their final positions ASAP? And then once you've done that, I'll put the implant in. Then I don't want those moved afterwards.
Yeah.
And then, so effectively what happens is you're moving a select number of teeth very quickly so that I can put the implant in, and then the rest of the teeth are kind of like delayed a little bit behind as well. I know it's not always possible, but can you give us your thoughts on that?
So I guess there are a few things that are really, really important in terms of predictability when we think about the biomechanics of clear aligners. So for Invisalign, it's one of the brands. And staging, so how you stage the treatment, how you stage the movements is incredibly important. So there will be times when we can very easily move teeth. It will prioritize those movements. But often what will happen is because it's a pushing system and because we're doing a force-driven system, we're not doing a displacement system like your direct-to-consumer aligners where there's no attachments, there's no force, it's just displacement, it's not force-driven. You may find that actually it makes sense if we wanted to expand, say, the canine, the premolar on the left-hand side, then to expand also on the right-hand side as well, because it's pushing. So it's, those equal and opposite movements. Or, if it's a derotation movement, it may be that rotation on a point isn't very predictable. We need to do a little bit of round tripping. So yes, we can get it there as quickly as possible, but sometimes it's not quite as simple as going from A to B. But what I like is trying to finish as much as possible at the same time. So when we can get the implant in, at the beginning or midway through the alignment phase. So at the end, the patient finishes their ortho, they get their implant crowns, they've done the whitening, they may have had a bit of bonding if they had a bit of tooth, everything's finished. They get those and it's a real wow moment when we can get everything to line up, when we've had that communication. And if we think of our patients as consumers in that patient journey, that's a real wow moment. So I agree, if we can, that's what we should be aiming for.
Yeah, and again, this is the conversation that I have with the Invisalign providers that I work with as well. Is sometimes I'll make that request and I'll turn around and say, "Pav, biomechanically, that's not possible." And then what we end up doing is we end up staging the treatment. So my preference is always to put the implant in as soon as what I possibly can. But sometimes what ends up happening, and good to get your feedback on this, is there'll be part of the Invisalign treatment that's done. Then I put the implant in, and then the rest of the Invisalign's finished around it. And sometimes that means I have to wait a little bit, which is absolutely fine with me. And I said sometimes it's the Invisalign dentist just like, I've crack on. This is where the teeth are going to end up. But as you said, it very much depends on the type of tooth movement that's required. Because if you've got a derotational movement to do, you need to overcorrect that slightly because you're going to have some rebound. And if I've got a rotated tooth around where I want to put the implant, it alters the trajectory of my implant. So I need that correction done first.
Yeah, absolutely. We don't want to be moving the teeth too close to the implant. Like if the implant's gone in, we want to be cautious about going on, that close to the implant. But when we think about implants and in orthodontics, we've been using TADs for many, many years, which are basically mini implants, right? Yeah. To help us with anchorage, to help us get some of the more complex movements more predictable. So actually, once we've got implants which are integrated, sometimes that makes our movements even more predictable because we have this absolute anchorage. And, so for instance, if we thought of a patient who had lost all their posterior support, when they've got anterior teeth, they've got crowding, everything sort of protruded forward. Instead of trying to get the anterior teeth aligned, which is going to be difficult because I have no anchorage, I've got nothing to support, I would prefer to phase the treatment as well. So we'd do phase one, put posterior implants in, let them integrate, put temporary crowns on, use them as anchorage to then align the anterior teeth and to get us back into, reestablish a proper occlusion. And then we can put the final crowns on. So you're almost doing, different phases and you're splitting the implant phases up then as well.
I think it goes back down to communication.
Yeah.
And it comes down to communication to the level of, you know what you need to do and what's capable. I need to know what I need to do and what's capable. bearing the end result in mind and working backwards from there. And sometimes it's a little bit trickier because, as you said, is, if you put in these posterior implants, and then if you as an orthodontist, I know you're not a specialist, so I don't want to mislabel you, but you're very experienced with Invisalign, is it gets to a point where you can't change your treatment plan if the implants are gone in place.
Yeah.
But similarly, is if we know what we're going to do, it may be that you stage some of the Invisalign treatment, and I will then place the implants, restore the implants, and then you use those for absolute anchorage and then move everything else around it afterwards.
Yeah.
So again, it just comes down to communication between two parties who are aimed at looking at after the patient's best interest.
Absolutely. And as you mentioned before, communication with the patient, because, so like with aligners, one of the biggest things that we fight against, and I say fight in inverted commas, is compliance. So imagine we plan all this and it's, it's going to be an awesome treatment plan. It's really going to serve the patient well and get them a fantastic result. And they don't wear the aligners because perhaps they don't really think it matters that much, or, whatever. And then it, again, in inverted commas, messes everything up. We have to make sure the patient's on board for that longer term treatment, because, I've definitely had patients who I've said, they think they come in and they're like, it's going to take me 3 months because that's what they've seen on, anyway, somewhere. And actually it's not quite as simple as that. Perhaps they've got perio, they've got extensive tooth wear, they've got, really severe issues. And they're like, oh gosh, no, I'm not going to do that for a year. That's totally fine. I'd actually rather know that now before we start than find out halfway in and we're worse off than where we were, than where we started off with. Exactly
correct. So I think the next question that I have for you is, certainly back when I was doing Invisalign, very, very long, that's a long time ago now, it was very much a case of you get limited root torque with these. Mm-hmm. And the only way to get true root torque and to get roots out of the way, if I haven't got, if the roots are tipped into the place of the implants and I haven't got space to place the implants, historically it's always been fixed ortho that's been able to treat that. Has Invisalign progressed to the point where you can do that type of stuff? Is it for pretty much anybody who's learned to place Invisalign, or is it actually it can do it, but there's a certain skill set that's involved with it? What's your opinion on that?
There have been leaps and bounds with what Invisalign can do. And I always say I'm very, very grateful that I started using Invisalign years ago, but I didn't start using Invisalign 20 years ago because I think I would have probably lost my patience with it if I'd started 20 years ago. So I think I started just in the sweet spot where it was really accelerating, and all these improvements, everything is much more predictable now. Of course, when we're talking about root movement and we are trying to get that root torque, so that root tipping, that is a challenging movement. Okay. And realistically, it's actually a challenging movement no matter what appliance you're using. It just happens that it's slightly more challenging in aligners, or is it more challenging in aligners than it is with fixed? However, there are ways to make it more predictable. So using it for auxiliaries, using TADs, we can use power arms, and I like to overcorrect my movements, so I will always add a few extra degrees of root torque, knowing that it's going to lag behind slightly. So I'll overbuild it into the system, because I know that I'm not going to get there because it's going to lag behind slightly. So if I push it further, I'll probably get where I want to get to. In terms of who can do that, I mean, I would never say, you shouldn't do something. If you feel you have the knowledge and you have that passion and you want to do it, then you should do it. You should try it. I think it's always really good to have a mentor behind you when you're taking on something that's you're stepping out of your comfort zone a little bit. At least, someone you can bounce ideas off. For instance, when going on my journey, when I've wanted to go outside my comfort zone, so I'm extruding an impacted canine. I took out the retained C. I did surgery, which I never do loads of surgery, but I exposed the canine. It was so exciting. I was having a ball.
You've got my interest now. You started talking about surgery.
I tell you what, it was actually in your old surgery as well. So probably using instruments that you used. So and then but I had that I've done similar cases before, but not to that extent. But I had that help and that guidance from a mentor. So I think, if you have that passion and you really want to be the best and you want to tackle new cases, then having that support network around you is really important. So for you, Pav, if you were working with an Invisalign dentist and they really wanted to try it, I'd say you'd be a fantastic mentor to be helping them with the implant and what you need, because you've been there, you've done that, and you've done so many cases. You can actually help and guide them as well, because you understand that restorative process.
Yeah, it's what you're saying there kind of like resonates with, and it's something that I've mentioned on this podcast very, very many times, that the power of a mentor is unreal. I've had so many mentors in my life. I still have people that I bounce ideas from. The reason why it's really important is because people have got different journeys and they're at different stages in their career. They've had different levels of experience. They'll have read different things to what you have. They'll have different insights to what you have. So even myself, and I consider myself to be relatively experienced now, I wouldn't say incredibly experienced compared to some of. Now I know, I've got a friend of mine who's placed well over 50,000 implants.
Wow.
That's like 5 times as many as I've placed. His skill and knowledge is just insane. It's on another level. But what it comes down to for me is, implants are effectively, they're just a tool, and it's how they're implemented. Yeah. And what I'm getting from you is Invisalign's no different. So it is just a tool. Yeah. It's how it's implemented that's important. And therefore, having somebody who's experienced with it, who's made the mistakes and is there to back you up to avoid you making mistakes. In fact, this reminds me of a conversation that I had with a friend of mine, and he turned around and said, Pav, so let me make one thing clear to you. He said, the people who you mentor will never truly appreciate you because you're keeping them out of all of the trouble that you've been through in your own career. Yeah. And he said people only appreciate something once they've actually been through the trouble of it. Yeah. So the fact that you're keeping them out of hot water, yes, they appreciate it, but they don't appreciate the full depth of how much you actually mentor. And I was like, well, actually not. Isn't that the whole point of mentoring? Yeah. It's from an implant point of view, that was Professor Brannemark's original philosophy. He was like, you have to train the next generation of dentists. You have to train them properly, because that's the way that the patients benefit, that's the way that the dentists benefit, and that's the way that the science progresses. And a lot of my mentors were trained by Prof. Brannemark. They have that philosophy and they've instilled it in me, which is why I'm so passionate about implants. And it seems like Invisalign's no different, really.
No, I mean, I think you're right. Having that mentor. I mean, even tonight, I know, in this, some cases take ages. We're talking a year. So when we first plan them to when we get the patient, finishing. I had a patient that I planned with my mentor last year. Crazy rotations on laterals, which we all know are really challenging movements to do with aligners. Okay. For many reasons, which we won't go into, but it's a challenge. Anyway, when this patient, we set up the staging, and it was slightly different staging to what I had done before. And I remember going, I really like the way I do it because I know it's predictable. And I was like, are you sure this is going to work? And my mentor was like, yes, of course it's going to work. And honestly, came in, one set of aligners, perfectly moved. I didn't need these big, crazy, ugly attachments. It was all to do with the staging, perfectly aligned, one set of aligners, no open bite, really beautiful occlusion. I was like, wow. And, imagine if I had been blinkered and said, right, no, I'm not going to listen to someone else's advice, and I'm not going to reach out because I know that I've got a way I can do it. And I have a way I can do it, but now I've got 2 ways I can do it. Yes. And it's like awesome. Like, that excites me so much.
Yeah. It's really fantastic. Yeah. So the next question I have for you is, in fact, before we get onto that, let's expand a little bit on something that we were discussing just before we started recording. And that is, there are some dentists out there where they get scared about putting in an implant and having teeth move around it. My response to that is really quite simple, is I don't mind that at all, as long as you're not getting too close to my implant. That's it. You don't get, with implant placement and with orthodontic movement, all that you're doing is you are triggering the healing response. And that's exactly the same with orthodontics. It's no different. Is you're triggering a response where the bone metabolism, in inverted commas, wakes up and you start to get bone movement. Okay, you're actually improving the metabolism of the bone. So as an implant surgeon, is if the bone around an implant increases in its metabolism and it gets healthier and better, as long as those teeth aren't getting too close to the implant to the point where we're going to have bone loss, because there are biological parameters that we have to respect with implants, and if you encroach on those, your bone's going to go. So as long as we respect those parameters, I've got no problems moving teeth around implants at all. That's absolutely fine with me.
Yeah, I mean, I will always respect what the surgeon wants. So I personally like having everything wrapping up around the same amount of time, because I just think it gives a very nice patient journey, rather than, we finish 6 to 12 months of treatment and then they've got to go through another 6 months plus of treatment. If it can be done, then I think that benefits the patient. But I will be led, or I will work with the surgeon to get the best solution for everybody. I'm not a surgeon, so for me it makes sense. But we all have different ways of working, which is
absolutely. And I've got some friends where they're just like, all I do is delayed implants. I've got other friends where they're just like, all I do is immediate implants, and they all get good successes. And I know some people who will place an implant and ask for it to be integrated and restored first before the Invisalign happens, and others will turn around and say, finish the Invisalign, then do everything. Yeah. From my perspective, I don't have a problem with that. So I think it's one thing not to do it because you don't understand what's going on, versus it's another thing that, okay, you've had the data, you understand the data, and it's your decision at that point. I just don't want people to be afraid of it, because, as I said, as long as you're respecting the biological boundaries of the implant, actually it doesn't give any negative issues there at all. So I think the final thing I want.
Oh, sorry. I was just going to say there's one case that really springs to mind where we delayed the implant, but that was because he had external resorption on his upper central, and the gingival margin was like 2-3 millimeters. It was crazy above the other central. And me and my surgeon were looking at it, and if we wanted any type of gingival symmetry at all, we were going to have to extrude this tooth with the external resorption. I mean, we were going to lose the tooth anyway. We had done our due diligence, been to see specialists, endo specialists, because I was like, if we can save it, we should. No. And so we extruded, and you should have seen the extrusion. I really overwent for it, because he had tooth grade small teeth anyway. So we really extruded, but because we were able to bring down, that the whole complex at the end, we had all this beautiful pink tissue that we could sculpt, and it's a bit sad because he has a low lip line, so you can't really see it, but.
You liked it, right?
No, but he was very switched on. He was very aesthetically aware, so he really understood what we were talking about, and he wanted it. I wouldn't put people through treatment for the sake of putting them through treatment to make me feel better, but he wanted it, and I was really pleased he wanted it, because it was a challenge. I love a challenge, and also going through that process and really having to extrude and actually the pink doing what we wanted it to do. It was so good, and it really showed how beautifully those two disciplines can come together. Yeah,
and I think that the final question the final thing that I wanted to discuss with yourself is, at what point do we say no? At what point do we say this isn't suitable for an implant with a combination of Invisalign? From my perspective, it's probably only those cases where it can't be done with Invisalign because it needs a bracketed system. Whereas perhaps the occlusion is really, really extreme, or it's just like the type of tooth movements that are required that it needs fixed appliance. Am I wrong? Have I got it right? Or are there any other instances where it's just like that's not really suitable for Invisalign?
So my favorite thing is doing Invisalign when everyone's told the patient they can't have Invisalign. Because normally I can get us to where we need to be, or at least like in a good, stable position. But yes, I agree. I think when we can't do implants and Invisalign is when something in the system is going to break down. So either the patient's not suitable for implants from oral hygiene, maintenance point of view. And it's really difficult, right? Because we know that when, I was actually doing some research into this a couple of weeks ago for a lecture. But we know that when patients are happy with the aesthetics of their smile, not only can they physically look after their teeth better, so because, the teeth are straight, they haven't got all the broken bits, they can get around the implants, they can physically do it. But not only can they physically do it, it changes their mindset. They perceive that they are more able to look after their mouth. So we obviously need patients who can maintain their teeth, maintain their mouth to be able to have more complex treatment. But also, I think we have to go a layer deeper and look at the motivation with the patient, because if we think we can get them there, then I won't say no now. I'll just say it's not yet, but give us a few months, work with us, and we'll get you there. And then the other time is if the patients, again, coming back to the patients and the compliance, if they're not going to wear the aligners and we need those more difficult movements, there's just no point. Like, it's actually far easier either to do no ortho or to put them in a bracketed system where they can't get it off.
Yeah. Yes. Yeah.
It has to. A lot of the times when we walk away, where we say we're not going to do treatment, is because we can't, or the parts that we can't control, the parts that we is on the patient side. So it's patient selection.
Yeah. So the parallels between what you're talking about and implant dentistry is actually enlightening, from a point of view that I see a lot of patients where their perio is just shot. Okay. And they've got active gum disease. And yes, I'll do full mouth reconstruction on implants in patients who've got gum disease because, you remove those teeth, you clean out the infection, they don't have gum disease anymore. And quite often, if you assess these patients, they're very much, you can see that the periodontitis has actually started because their teeth have been so crooked. They've not been able to look after them. And you get them into something better, healthier, easier to maintain, and all of a sudden their problems go away. Now, I do still take into consideration osteoimmunology and, but patient compliance. And if I think that they're not going to comply, then yes, I don't do it. In perio patients, I also use implants with a machined neck, so it reduced risk of periimplantitis. I know a lot of dentists will turn around and say, you shouldn't put implants in patients with gum disease. I think it's very different for a full arch. If you're removing everything, that's very, very different. So the parallels that you're describing are quite interesting, actually.
Yeah.
Obviously, if the patient needs one or two implants and they've got active gum disease, the perio needs treating first, 100%. But if somebody's got a terminal dentition and turning around and saying, well, you've got periodontitis, therefore you're not suitable for implants, for me, that's along the lines of saying, well, you have a cancer, but you're not suitable for chemotherapy because you've got cancer. Those are the patients who need it the most, if that makes sense.
Yeah.
Listening to the parallels is very, very interesting, actually.
There's a lot of parallels. I really, it's not, if we think about, perio, and it's not just perio, it's lots of things are symbiotic. It might be occlusion, like what came first, the chicken or the egg? Is it the crowding? Is it is it the anatomy of the teeth? Is it the occlusion? Like what came first? Like what broke down in the system first? Like, you'll probably never know. But what we can do is at least we can take where we are and get the patient to a better position. And this is why I really enjoy working in sort of that multidisciplinary way, where I don't do everything. I do the bit I'm good at, and the patient speaks to and sees people who are as good as they can be at what they do. So, I work with peri specialists, I work with endo specialists, I work with, implant surgeons. And the whole point is that we get this really good result for the patient and we give them long-term oral health stability. Because I think if that's our aim with everything we do, I mean, how fantastic that you can change someone's life and give them oral health stability, confidence. I love it. I really love it.
It's great, isn't it? I'll tell you who'd be phenomenal with this type of stuff is somebody like our friend Chetan, who does Invisalign and implants to an exceptionally high level.
Yeah.
If he's listening to this, he was just like, "What are you two on about? Just do it yourself."
Do it yourself. Gosh, no. I don't think I could do what you guys do. That a little dabble here and there, guided, is fine.
Come and watch a Zygo case. You'll love it. Drilling up here by the eyeball. It's great.
So I have a real issue, and this started at dental school, right? I would be you have to watch oral surgery before you're allowed to do anything, and you have to nurse. I fainted every single time, to the point where my tutors were like, "How are you going to be a dentist?" And I don't know, because I kept fainting. So it turns out I'm actually fine with blood if I'm controlling the blood. Like if I'm working in there and, fillings, gums, everything's bleeding sometimes. That's fine because I'm concentrating on doing my job. But if I'm just watching someone else create all this blood, I can't do it.
So how about this? You do the Zygo and I'll assist you. Then you'll be okay, right?
No, thank you.
So, Millie, I mean, we've been going on for about 45 minutes now. I think we've given the listeners a nice oversight of kind of like balancing Invisalign and implants. If the listeners wanted to find you to pick your brains a little bit more, what's the best way for them to find you?
So the best way is probably through Instagram. So it's just at Dr. Millie Morrison. And shoot me a message on there, and I'm very happy to help. And we can, happy to help via message or Zoom or, whatever people want or need. So Instagram's probably the easiest way.
Yeah, I think you talk Invisalign as much as I talk implants, which is saying something. So
it's a problem, but it's okay.
Oh, fantastic. Millie, thank you very much for your time this evening. Folks, thank you very much for tuning in and listening. If you have any topics that you would like for me to cover, please reach out and let me know. I've got some more topics that I will be recording over the next few weeks as well. And I really appreciate you all listening. Please ask your friends, colleagues, family, dogs, cats to listen to this. If you've got fish, I'm sure the fish would love to hear my voice as well. It's all very much appreciated. We just want to spread the word about implants and now Invisalign as well, apparently. So yeah. Folks, thank you very much, and I will speak to you soon.
Thank you so much for having me on.